Okay. Well, let's go ahead and get started today. And thanks for coming for our imaging conference. And today we will be addressing contrast echocardiography, a topic that is dear to my heart as well as yours. How about that? And the reason for it is, you rarely in the field, and we talk about this, is you rarely in a field talk about contrast as a material. And angiography use contrast all the time. You can't have definition of the vasculature without using contrast. But interestingly enough, contrast for echo is a bit different. And as you know very well, these tiny microbubbles that traditionally have either microcavitation or air will reflect speckles of ultrasound and gives you an image and gives you a white reflectant of an image. And most often, and traditionally we've used it to detect any shunting, either intracardiac or intrapulmonary. And the reason for it is if you agitate any fluid and you have these microcavitation, or even put a little tiny air and then mix it, you have these microbubbles that are about maybe 10 microns or so. And 10 microns for the body is rather large. So when they go in the right side of the heart, gradually the air dissolves and they get trapped in the pulmonary circulation, and you don't see anything on the left side. Intracardiac shunting, just like you see in this premium atrial septal defect with nice crossing of the contrast. And if you will, pulmonary AV fistula that we see frequently now with liver disease and liver transplants. And usually it takes the time that the blood will go through the circulation. So usually about 5 sides. Cumulative, and you gradually increase over. To try to enhance, do you enhance it? Because if you have more, how do you get a Doppler signal? You get it because of reflectance from the red cells in the blood. So just imagine if you have other microparticles that are quite reflectant of ultrasound. You will enhance that signal, and if it is important, you'll use saline contrast to try to enhance that. So that's the extent actually of today of how much we're going to talk about saline contrast or agitated contrast of fluid. So in concept, this micro bubble has traditionally air, but people have worked on the field with a lot of investment of time and money over, I would say, close to 25 years to try to develop tiny microbubbles that will cross the pulmonary circulation. So they have to be, as you would think, they would be smaller than your 10 microns, etc. And usually, as you will see, they're about maybe 1 to 3 microns. You'd like them to last a little longer, so the shell in green has different characteristics. Could be protein, could be albumin, could be surfactant, other things. And high molecular weight gas to, still inert gas that is doesn't have any really biological effects. And this is a summary. First one is Optison, then Definity, and then Lumason as of recently. And as you could see, the size of the microbubbles is between 1 and maybe 4. That's on the average. The shell composition, denatured albumin, phospholipid, or lipids and surfactants. And the gases perfluorant, usually there are perfluorocarbons, high molecular weight. In green, actually, the first didn't materialize in the industry. Levovist is available throughout the world. It's a starch, galactose. The last two in white are actually people who've spent millions and millions and millions of dollars and never made it because they were trying to go for a perfusion indication and did not make it in the United States for a perfusion indication. Okay, well, this is a beautiful image, as you could see. Something that you'll be very proud of now. And basically to illustrate the power of such a technology, right? You can't see a thing. And by injecting any of these newer agents that have been approved for several years now, you can see the heart very nicely. And the prime indication, and this is the element, that this would be an indication, basically an endocardial visualization, from which you can extrapolate for ventricular volume determination, ejection fraction determination, and so many other things. But this is the prime indication. The other indications that at times you use them here, they're really not approved for that particular indication, which is enhancement of Doppler signals on the left side. Stress echocardiography, we'll talk about that, is still not approved for that indication, although one of the companies is actually conducting a study. I don't know where it is at this stage of the game, but not yet published. So you will see some indication for that. Now, one thing I've noticed in the lab, and I would say it's beyond this laboratory here, is to try to really understand what goes on in contrast from an interpreter point of view, understand some of the advantages, limitations, knobology that is needed, and if you see an image, to be able to tell whether this image is not good because of three dots, dot, 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 of what is the issue. Is this less contrast? Is it too much contrast? Is this something in your setting that is not well? And I would urge you to learn this. You need to really know what goes on, because otherwise you're not going to push that contrast to where it should be. Jorge Sharif, when he was with us, and now he's in Dallas, many, many years ago, I would say 25, almost 30 years ago. We took some of these contrast agents. It was Albunex at the first time. You put it in a little beaker, and you put an ultrasound on this. After a little bit, you start seeing the beaker itself, the first phase and the second phase. So, oh, that's interesting. I mean, why does this happen? Well, turns out what happens is if you have a lot of concentration of microbubbles in a beaker, it acts as a very super duper reflectant. So from the first interface, you reflect most of the ultrasound and you're not going to be able to penetrate. And if I cannot penetrate a certain surface, I'm not going to be able to reflect anything back. And what happens over time is if you expose this medium to a lot of this ultrasound, interestingly enough, you start destroying some of these bubbles, and once the destruction is enough and you can penetrate, then you can start seeing. Now, do we see this phenomenon in humans? Yes, you do this phenomenon. You see it every day, okay? And so if I'm injecting too much contrast, and nowadays I think most laboratories, although if you look at the package insert, it doesn't tell you that you need to dilute it. Most people do dilute it. It's not going to affect the efficacy of the contrast. Part on the right side first and then on the left side, and gives you this attenuation. So what I'm going to show you here is basically an example of what happens when you inject a large bolus. What you see here is, yes, low intensity first because we use a low MI. Watch the contrast now coming into the left ventricle, right? I can see the left ventricle very well. And basically what you have here is such a high concentration that most of the ultrasound is blocked right here. All of it is reflected, goes back, then I don't see anything behind it. So once you see such a phenomenon, you know you're dealing with too much contrast. That you should know almost instantaneously. That is actually not too little, but too much contrast, at least as a bolus or a high concentration. What happens? Well, if you have such a thing, you just wait a little bit, and it dilutes, and you can start seeing again, right? If you're too anxious, you can increase the mechanical index, and we'll talk about it. You destroy a little more, but you really don't. You don't need that. And basically that will be taken care of. Okay? So we already touched on few things. One is that actually these microbubbles have a certain high. Two, they interact with the energy that you're sending, which is the ultrasound waves. And if you think about these ultrasound waves, the way, if you remember the first lecture of has been viewed more than 11,000 times. That first lecture tells you that I send packets. See this little wave there? Usually there are packets of about 3 or 4. And in that packet, there's an intensity to the wave, positive as well as negative. You see the positive here, right? And then the negative going down. This, every time they're exposed to this ultrasound wave. And if it is on the positive pressure portion, right, what's going to happen is they're going to shrink it down. So they to differentiate a high from a low pressure. I mean, the frequency is very high. But I think this is just to illustrate the concept that this mechanical index, or MI, which is visible on your screen, and we will, is very important in your settings. So this is how you dial in the energy, and the MI is peak negative pressure divided mechanical index, too much energy, too much negative pressure. I'm going to destroy these microbubbles quite fast. And that's not what you want, right? I mean, we may need it for today applications. So we discovered over the years, and this is, this illustration is, I would say, about 20 years old, is that this mechanical index on the x-axis, okay, and then lower mechanical index to medium to low power, about 0.2, even 0.15, mechanical index. So what does it mean? Well, if I'm on the high end, which is usually my routine imaging of the heart, right? If I'm going to inject contrast during this time, I'm going to destroy most of it very fast. And it's going to have a certain pattern different of what you've seen with the attenuation. So if I can dial down my mechanical index gradually, right? I'm going to preserve, I'm going to destroy less, I'm going to preserve them more. I'm not going to see as much before I inject contrast. The image is going to look faint because it doesn't have much reflectant, but certainly it will enhance the ultrasound and will destroy much less. Okay? So that's, in general, what we're talking about. So let's go through some case examples, if you will, and see what is the effect of a mechanical index on contrast intensity. So what I want you to see here is this is the MI. See this MI is 1.5. And what I'm going to do is gradually decrease it in the same sequence of beats. All right? And see what happens to contrast. So I'm going to start with a very high mechanical index. Notice that every systole, there's very little contrast still there. So we're going to start decreasing this, see this, down to 0.7, 0.6, 0.5, whatever it is. Contrast now fills in the whole ventricle, and I don't see this destruction. Okay, now it's back on, very high mechanical index. Notice also, besides the negative, the black area, meaning not filling with contrast, there's a lot of swirling. So that's one area that for you to be sensitive to. So if I see a lot of swirling, And at the base looks like very nice contrast intensity. Correct. Is the MI, is the mechanical index too high for that particular patient? Okay? Got that? That's simple. All right. So what do we have here? This is the mechanical index. Kind of stuck there. And this is some other examples here. That's a high mechanical index of 1.1. And you could see basically, you're going to see here that it's clearing every systole. And interestingly enough, what do I have down here? I have attenuation. So, you know, different mechanisms here of contrast, and you know the image is not good. So at least from a sonographer point of view, if the image is not good, understand why it is not good. Is my mechanical index not set right? That's going to be very important for you to address. The other area of contrast, so we talked about mechanical index, right? We talked about attenuation. We talked about, you know, the importance of mechanical index to preserve these. The second, I think, most important, you know, principle, I think, if you were in contrast, is the concept of harmonic. And this is fundamental. Let's say a transducer is emitting at 2.5, you know, megahertz frequency. When it hits, you know, different structures, if you will, it may emit resonant frequencies, which are either multiple. So I always give an example of if you hit a hard wire, if you're a piano player or a string guitar player, if you hit it nicely, it will give you that fundamental frequency of whatever that string is, like ping. But if you hit it very hard, you know what happens? The part of the properties of these is to emit not only the regular frequency, but multiple of that frequency. Like, instead of ping, it will be ping. You'll hear the multiples, and usually either the higher frequency or lower frequencies. Same thing happens to these little tiny microwave at a certain frequency. Interestingly enough, is that they emit. So once they're stimulated, they'll emit the fundamental frequency in addition to multiples. This is actually where the research started in trying to figure out how do you optimize contrast imaging. One byproduct of that was what? Was your regular harmonic imaging. We found out, we never thought that the myocardium per se will emit second harmonics. Okay? And actually the myocardium emits second harmonics. And remember in my first lecture, if I'm imaging at 2.5 and it says H 2.5, meaning harmonic 2.5, remember, I'm imaging at 2.5, meaning my emitted frequency is half of that, is 1.25. So don't feel too good if the number is on the high side, because your resolution relates to the fundamental frequency. Okay? So, where's David? Is David Gomez here? David is not here, but I know he loves to image at a low frequency, and that's why his images are more coarse. Because if you image at 2.5, all right, the myocardium, you would have emitted at 1.25, and that's why the image looks coarse, looks grainy, much less resolution. Contrast, and the beauty of contrast is actually you need to image at harmonic. Why? As you will see from this example, it emphasizes contrast in relation to the myocardium. So in this example here, what you're going to see is this is my mechanical index of 1.5. This is 3.5 megahertz. Okay? So notice with one flip of 3.5 megahertz to harmonic, you will see an H. See what happens to the image. So this is the same patient within a fraction of a second difference. So take a look at that. This is fundamental imaging. It doesn't look the most appealing thing. I mean, like, oh, this is harmonic. Okay? And we're going to go back to fundamental. And this is harmonic. It's quite a difference, right? Why? Because in the first one right here, this is fundamental frequency. This is basically, I'm imaging at and I can differentiate much less between the myocardium and the cavity itself. What happens is the signal from contrast is much more intensified compared to the myocardium, and therefore I take the advantage of having a nice contrast. Now for sonographers and the physicians, you know, if you use contrast nowadays, you know, there's a preset, right, for contrast, and it turns on your harmonic. But if you're a novice and you have a brand new machine that has not been, you know, customized for no presets or nothing else, you need to know this, right? You need to know this so at least you could do a good job at it. So that's the importance of harmonic. So we learned two things, okay? Mechanical index is crucial. Otherwise, you're going to destroy a lot of things. And the way the destruction is going to look like, almost like a hurricane heart, right? If you had that, it will be grainy throughout. Grainy in the atrium, grainy in the ventricle, right? It just had a, you know, so a high mechanical index will give you a little different vision where you get into trouble. Get in trouble of optimizing the image. Why? Because in an apical aneurysm, you have a lot of swirling and you don't have flow coming in and going out. So you have stagnation of that portion of contrast, and then you're waiting for contrast, fresh contrast to go in, and it's going to get exposed to ultrasound quite a bit. Okay? So not infrequently you'll see the swirling. You bring down your MI as much as possible to preserve this contrast concentration. And at times it's hard for you to be able to preserve it, so you inject a little bit of contrast more to see how much you can fill it. So, but this is where, you know, you have this. One, you need to optimize MI down, way down, so you can destroy much less. But at times, if you have a lot of stagnation, you know, this contrast is exposed, you know, to the ultrasound throughout, although it's a low MI, and it may be a little difficulty to do that. But I think knowing this, then you can adjust, right? And remember, if you have too much contrast, you're going to have some attenuation, right? And your worst nightmare is from a fault point of view is I have a swirling here, right, in a normal ventricle, and at the same time I'm destroying too much in the apex. Got it? All right. So that's, I think, the basics, and what we're going to talk about is some applications and various things. So what contrast is approved for is endocardial border definition, and we talked about that. So if you go to any package insert, all the three of them will have that. We use it within that context, again, off-label for stress echocardiography. We use it also at times for enhancement of Doppler signals. And Dr. Little is not here, but I know he's done some investigation that contrast will increase those. You may enhance it a little bit beyond of what actually the velocity is, and it could be a half a meter, which can increase the gradient significantly. So you got to be very careful. Coming to give you grand rounds, Dr. Jonathan Linder, and his mentor, Dr. Call and Porter, and Dr. Shamsi Pasha is here. He came from Dr. Porter's lab. There's a lot for that. There is a code for billing purposes, but no reimbursement for that. And it has some challenges nowadays. And therapeutics, you know, if some of these contrasts actually can tie into a thrombus, actually, and if you insonate them, they actually may enhance thrombolysis. And people have done some of that work. Dr. Porter has done some of that work. And what's available for you in the literature for you to review, this is the first consensus document in 2008, so 10 years later, just last month, an update. Actually, Tom Porter chaired that imaging group, writing group about contrast applications. And in it is most of the fundamentals that we just talked about, in addition to some of the other applications that are, again, not, you know, I guess not FDA approved for that particular, you know, application, but, you know, along the lines of what do. All right, so day to day, these are our clinical applications. Number one is evaluation of regional and global function. And we'll go through some examples, some of the pros, some of the cons. Rescue of uninterpretable studies in the ICUs, definitely, and this is the major indication, really. Improved stress echocardiography, we use it not infrequently in our lab, and we validated that. Doppler signal enhancement of aortic stenosis, pulmonary veins, rarely if ever, but definition of structural abnormalities, thrombus, I think it's used quite often for that, very appropriately so, and maybe some pseudoaneurysm, looking at flow of where the flows come. So let's go through some examples. Well, if you take a look at this heart that gradually will start moving, you can't tell a thing. I mean, I can poll you and you could take any. I'm amazed, actually, if people are seeing such a thing and are not using contrast in their own laboratory, how would they interpret such a study? Would they interpret it as completely uninterpretable? And to tell you the truth, many people will. They may put technically difficult study, but they'll give you an interpretation. And this is where the danger comes. This is really where the danger comes, because people forget about the qualifier of a technically difficult study. And this study, you can't interpret a thing. Zero. All right? And you'd better, if you're not using contrast somewhere, or, you know, the and this is that same patient. I mean, like, my goodness, what a difference, right? So it really rescues studies. How about this person? There are a few things that you can interpret. There's no question about it. I can see, and the reason I'm giving you these previews is that this is I'm not picking just one beat. The severely depressed ventricle, there's no question about it. The walls that I see are dysfunctional significantly, some akinesis in the inferior wall, apex probably akinetic, basal lateral wall is functioning. So I could say severely depressed function. I have no issues with that. But, you know, the sonographer astutely enough used contrast in this individual. I can see the other walls, but I can see something that would change my medical management. No question about it. So in patients who are bad heart failure, I mean, you're almost obliged, you know, not to interpret basically how depressed the ventricle is, but this is something that you will harbinge and will change your medical therapy, whichever way you look at it. How about this individual? Looks like hyperdynamic. I can't tell about regional function. I would guess that it's a hyperdynamic function. And this is this individual. Actually, it's a patient of Dr. Naga. And that's a hypertroph. Quite a different. Even the septum looked, you know, generous, but I think certainly much more impressive than the other one. In this case, I've shown many times. I still like to show it because it just reminds you that at times it could be very localized. I interpreted this study as normal. It was before digital. And these are the best views that you can get. So interpret ask be that this is completely normal. Patient had a very abnormal electrocardiogram with what looks like an infarct, and the infarct was in one breast. And it was amazing to me because the only area that was not really well visualized was like about 2 o'clock. And I mean, I've never seen a localized aneurysm just in the lateral wall and sparing the apex. It was a learning experience of something like this. This case I remember very well. Mike, I don't know if you remember that case, but this was a live case at the Washington, depressed ventricle. Suspicious of the apex, maybe an apical abnormality, and that's all I can see. I mean, I really would pity people who are not using contrast, and I say that because this is an available, it is a medication, it's a drug that can convert something that you have to guess very hard for it. And we're preaching to the choir here because I think we use it very appropriately. But you need to know that there are many laboratories who don't use it. And the utilization currently in the States is probably about 3%, has increased maybe less than 1% or so. So quite a low utilization. So what do you think about this case? Take a look at that. This is your Gardenvariety, right? Apical hypertrophic cardiomyopathy with a spade-like apex. And yes, it can give you this, but you cannot differentiate it from ischemia early on, right? Somebody comes in like this. So it changes your diagnosis completely. Completely. All right, how about this case? Take a look at this case here. Let's see if they're going to play by itself. Yeah. All right. This is not hard to interpret, actually. I mean, you're seeing enough myocardium, right? Well, what do you see? Just say it out loud. What do you see? What can you call with confidence? Jason, come on. Yeah, inferior wall base is akinetic, right? And then hypokinesis here. Anything else? Inferior septum here. It goes along with this guy, right? It goes along with the same distribution. Well, there must be something else because that's why I'm giving you this case, right? Abnormality on top of that, and we have a thrombus on top of that. Isn't that interesting? And seemingly, what looks like is a, I mean, I wouldn't say completely decent, but semi-decent with a small d, right? It is really amazing, right? So the more you see, the less confused you are, and the more the accurate diagnosis that you. Man.
Looks like kinetic here.
Huh?
Looks like kinetic, but it could be just apical hypertrophic also.
Or an apical hypertrophy. True. That's your differential diagnosis. Notice one hint also, that as to the abnormality, see this? It has to move. Okay? Endocardial moves much more. Epicardium moves about 10%. So if the epicardium doesn't move, you got two choices. Akinesis,
Just doesn't have anywhere to go.
or it doesn't have anywhere to go. Indeed, that's the situation. So just for interest, I'm going to go back through all the slides and point to them so you can see. Look at this. I mean, this is an amazing apical hypertroph, and you could see actually the arterioles, right, that are filled with contrast going forward. Okay. This is a question for you. Okay. The technical things that are going in this, right, everything that we talked about. Which one shows attenuation? Which one shows a high MI? Are you happy with this picture? You're happy. How about this picture? Attenuation, right? Very bright, and I can't see anything behind it. This, so we're not done yet with attenuation. Actually, it's even worse, right? How about this guy? It's getting better, right? These are sequential region, right? So it should tell me that, you know, I need to do my homework once I see the image, right? It's getting better. What happened from here to here? What happened? Huh? More contrast. Somebody gave an injection of contrast between this and this. Much more bright. High am I, right? It's not even displayed, but I know, right? I know. Okay? So somebody either got anxious of too much contrast, or this is, you know, towards the end or whatever it is. But this is very important for you, right?
Bill.
Yes, sir.
One thing that we don't talk too much about, but I imagine that if you want to enhance Doppler,
I don't know if you could play it. I don't.
I'm
I mean,
not-
the
I'm
question
really-
is.
because we don't normally think about it, but if you are also trying to see more, so I'm assuming that it perhaps might be better if we have it a little lower. I never even thought about it before.
I never thought about it, but I'm not sure.
It's an interesting.
And it still is the same, meaning my impact is probably much more in stress echo because of the urgency of the diagnostics, if you will. But I think the first two are about the same. ICU, instrumented patients, inpatients. Outpatient is the least impact, and we use it the least. Actually, we were able to demonstrate all this. But I'll share some of the original data. This is from our original data back, let's see here, Dr. Yongki Kong, published in the American Journal of Cardiology, and just tells you that in patients who are in the ICU who needed a transesophageal to define ventricular function, that contrast gave you pretty much good visualization with similar diagnostic accuracy to transesophageal echocardiography. So that's one. Two, yes, you could use it in stress echocardiography almost off-label, and I think most laboratories do. There are some laboratories who still don't use it at all. Some other laboratories use it 100% of the time, and the truth lies somewhere in between. This is a patient. You could see the ischemia here at high dose. At the medium dose, actually there's hyperdynamicity of this heart. This patient came into the emergency room at least 3 or 4 times, was cast at some point in time, and had a normal coronaries, to tell you the truth. The normal coronaries were the bypassed coronaries, and they felt comfortable that indeed there was a bypassed coronary, but the native arteries actually progressed and had significant ischemia, addressed after his bypasses were told to be normal. So current utilization in the US for stress is still between 0 and 100%. It's amazing. Our utilization is about 60 to 70%. These are data from Juan Carlos Plata when he was here with us, and what we did is something that we're not going to do again, is 2 dobutamine stress echoes, one randomized, one with contrast and one without. And had almost 100 patients. The rest and stress watch what happens with stress is actually some of the images may get degraded a bit. And the impact is, if I have, my impact is much higher than if I see all the segments. I should not use really contrast. If I see maybe 1 or 2 segments, the impact is much less. So I guess if you're not happy, you have to decide. If you're not happy at rest as well as during stress. And here you go. How are you going to interpret this study? Baseline, 5 mics, 10 mics, and 30 mics. And trying to interpret this study, I'm not either helping my referring doctor or not helping the patient, right? Because if I use contrast, I certainly can understand what the situation is. To start with, is at baseline, I have a dyskinetic apex. So I know I have a wall motion abnormality at baseline. And notice what happened to this heart. Heart dilated. I couldn't tell whether the heart dilated, yes or no. So it's an indicator of bad ischemia that has extended to the anterior wall. Now, not everything is hanky-dory with contrast. And I think you need to know that, because contrast can have some issues with it and can fool you at times. Contrast is great for apical issues. Where contrast falls apart, I wouldn't say falls apart completely, but can be not necessarily attenuation, but shadowing that comes from contrast. And it could be in the one thing, linear structure, straight line structure in this heart. If you see something that is straight line, you know you got to be careful about that. So the question to you is, in the inferior base here, what your eye is getting fooled with is this linear density that's coming from the papillary, right? The endocardium is way behind here, and the endocardium is way down here and not there. The eye is fooled during motion of that, this black shadow, that indeed this is the myocardium. So this is very important for you. And this is difficult. Now, if you see this linear structure here, at rest and during stress, enhances, reproducibility is better. I don't know. I really think personally the appropriate use is somewhere close to maybe 60% or so. It's not 100%, because if you use it 100% of the time, so if you have pristine images, I would stay with them. Actually, I had some pictures where you had a beautiful echocardiogram, and it will actually deteriorate if you use contrast. So you got to be very careful about that. Optimization is necessary. I mean, your imaging window may be a little different. For every time you use contrast, almost re-image the heart so you can see the whole areas about the heart. 2 other studies, and we'll close it. One is, this is an important study that from our institution that actually is probably among the most quoted studies for impact of contrast. This is when Mohammed Kurt came from, he was a medical student or an intern, whatever it is. I don't know where he is now. I've checked on him. He's graduated. He's doing. He stayed here for a whole year, and he had a newborn. Actually, didn't see him, and there was no FaceTime at that time. So he was amazing. But we had this idea of actually trying to test and see what is the impact of contrast. And the beauty is that we empower our sonographers to do contrast whenever they want to, right? Whenever it's indicated. So we had 632 consecutive patients required contrast because of technical difficulties. And what we wanted to do is look at not only the images, but also did it change what the physicians would do. So what we did is actually, he would call them with the results of the non-contrast study and said, well, and we'd give them the information. If you can estimate an EF, you give them an A. If I can't estimate an EF. And the physician decided on whatever it is. Said, Dr. So-and-so, actually, this patient got contrast, and actually the images are like this. What do you want to do now? Okay, so that's what we did, and actually you'll see what the impact is going to be. So these are by definition technically difficult studies, so they were either uninterpretable, the 20% uninterpretable were in the SICU. The others are pretty much technically very difficult studies. They became adequate, the vast majority. However, in the SICU, we still had some technically difficult studies, and it actually mirror image what we see every day. I mean, yes, you'll convert the vast majority, but not all of them. Impact on additional planned procedure. TE avoided. Also, the majority of impact is in the instrumented patients. SICU predominantly, then MICU. This is inpatient wards, this is outpatient. So the least impact is in the outpatient. Avoided in about 23%. So the vast majority of the impact is in surgical intensive care units and medical intensive care units. These are medication changes. At times you think the ventricle is hyperdynamic or hypokinetic, and you change hemodynamic drugs. So hemodynamic drugs either started or stopped. Anticoagulation either started or stopped, depending on what you saw in the apex. And this is the overall impact. Overall impact, close to 60% in the MICU, about 30-some percent. Inpatient wards, a little less, close to 30%. And in the outpatient unit, maybe about 12% or so. And I asked actually Mohammed to do this analysis. If you had more and more of the segments that you can't see, the impact is higher and higher and higher. If I don't see the vast majority of this heart, the impact is almost 100%, right? And this is before your time. There were concerns about, and there was a black box about contrast as to causing an acute myocardial infarction or some other issues, etc. Most of these black boxes have been taken away because of data, actually. Studies were done. To the guidelines and consensus statement from ASE, this is a table that summarizes the data on Ellie and Dr. Sheikh. Whereas Dr. Sheikh is in Austin, Dr. Egeli is back in a mainstay of utilization. It's a great tool, as you'll probably see in grand rounds. Unfortunately, I'm not going to be here. I'm going to be at Mayo. But quite a bit of that is actually very nice technology to use in the animal models about repeated perfusion depending on. Up here and ask any questions. Thank you. Yes.
Can I make a suggestion to the sonographer and fellows to pay attention to the wall motions during contrast administration, because there are a couple of cases that we've seen last year that give us some doubt about very transient myocardial depression. And that will only be solved if the sonographer sees for a long period, images for us to decide is it a true phenomenon or it's just a matter of how the image was acquired.
Yeah.
Yeah, that's you showed me one.
Yeah.
I saw one.
Yeah, very transient.
This is a transient. I mean, the question is about transient myocardial depression. The cases that one or two cases that you showed Dr. Chang was real.
They look real.
It was real, and I didn't see any PVCs, I didn't see any ectopy, etc. But we use it so often that we don't see it, so it must be something very unusual in those cases, right?
But when you do the sonographer, when you do the study, probably you want to acquire
Yeah, because if that's all you see, you're going to then make a call thinking it's permanent, and it was transient. That's the problem. What he's trying
Yeah,
to say.
is trying
Maybe
to
it's good to record.
to record a little longer.
longer.
Yes.
Contrast was used more often, or that we know it's low, we know it's poor function, it's not needed?
I'll give you my
Sir.
5 cents. One of the important criteria for how well an LVAD is functioning is how big the LV is. And what we see sometimes is LVs that look like 5.2 without contrast becomes 6.5 after contrast. So the ventricle. Because that's one of the criteria that can be very helpful. And of course clots.
Or if there's a clot, yeah.
And then my second question is, with LVADs, I haven't found that there are any issues with alarms going on. With ECMO, I've told that we can use it here with ECMO. However, those can set alarms off, and when that's happened, I've told them they can consult the lab and predetermine. But what's your thought on using?
The question is, can contrast use set an alarm in ECMO?
It can.
Yeah, I just don't know, and I'm glad you told me. So
Yeah, from my understanding, it could potentially
It's the membrane.
shut down the machine
Yes, sir.
or something because of the bubbles.
So the question is, do we need? I mean, at some
Yeah.
point in time, we're gonna need it.
I've used
I
it
don't know.
once where I didn't set off any alarms. I've used it other times.
But it's setting an
Great.
alarm, so there's something. I think we need to research that portion.
Yeah.
Yeah, it's something.
It's the air bubbles.
We need to research it
Okay.
and ask maybe if a forum.
Yeah, at some places I've worked, they've said we were using it and then we stopped using it because of that.
I mean, if the alarm is artifactual, I'm not. I would be concerned, obviously.
One plea I do have is we're still not using enough, just even saving contrast for pulmonary pressures. And we're seeing a lot of hypertension patients. And we end up saying we cannot assess pure pressure. So please, keep that in your mind to use contrast when you cannot get a good TR. In those people they're already coming to the lab because of pulmonary hypertension. And sometimes.
Well, thank you very much for coming. Enjoy your day.
Do you know?